Chalo, let's begin. You see this quote on the screen? Children are not just little adults. Beta, you have to burn this line into your brain because it is the absolute foundation of pediatrics and it's where we start today. It's a very important reminder that a child's body isn't just a mini version of ours. No, not at all. It's a system that's constantly growing, changing, with its own unique weak spots and its own unique diseases. So to understand what can go wrong, we have to forget our adult-focused thinking for a while and start completely fresh, bilkul fresh. Okay, so what's our plan for today? We're going to break down the challenges of early life into four main parts. First, we'll look at what happens when there are errors in the blueprint. These are the congenital anomalies. Then we'll talk about the huge challenge of prematurity for babies who arrive a bit too early. After that, we'll see what happens when there's an invasion from outside by nasty infections. And finally, we will investigate a very serious condition called fetal hydrops, where a fetus becomes full of fluid. So are you ready? Let's begin. All right, our first section, errors in the blueprint, or what we professionally call congenital anomalies. Now, listen carefully. The word congenital just means present at birth. That's it. But here is the most common mistake students make, and you must not make it. Congenital does not always mean genetic. The problem isn't always in the DNA. Sometimes the trouble comes from the outside world during development. So let's start with the first type, a malformation. This is what we call an intrinsic error. The best way to think about it is like having a faulty architectural blueprint. Right from the beginning, the plan for how to build a particular organ was wrong. So, of course, the final structure is formed incorrectly. The problem came from within. Simple as that. Next, we have disruption. Now, this is the exact opposite of a malformation. In this case, the blueprint was perfect, the construction was going on beautifully, but then some extrinsic force, think of it like a wrecking ball, comes from the outside and smashes into the building. It causes secondary destruction. So the original plan was fine, something from outside came and broke it. And our third one is deformation. This is also an extrinsic problem, but it's not a violent wrecking ball. It's more like a slow, constant pressure. Imagine a small plant trying to grow in a pot that is just too tiny for it. Its shape will get distorted, right? In the same way, if there isn't enough space in the uterus, the compression can apply mechanical forces that alter the shape of a perfectly normal developing part. This is a common cause of things like club. So let's summarize, because this is a guaranteed exam question, Beta. You have to know the difference between an intrinsic error and an extrinsic disturbance. It's simple. Malformation is intrinsic, a problem with the blueprint itself. Disruption and deformation are both extrinsic, outside forces messing with a good plan. You got that? Good. And look at this picture. This is a perfect textbook example of a disruption. What you are seeing are amniotic bands. Basically, the inner membrane of the amniotic sac can tear, creating these fibrous strands that float around and can wrap around a limb, or a finger, or a toe. They act just like a rubber band, cutting off blood supply and stopping normal growth. They can even cause amputations in the womb. A totally normal limb, its development was literally disrupted from the outside. Now let's talk about a sequence. A sequence is a domino effect. One single problem starts a chain reaction that causes a whole bunch of other problems. The classic example you must know is the Potter sequence. See, it all starts with one big problem, renal agenesis, which means the kidneys do not develop. Now, most of the amniotic fluid is actually fetal urine, so no kidneys means no urine, which means very little amniotic fluid. This is oligohydramnios. Without that fluid cushion, the fetus gets compressed, which leads to underdeveloped lungs and a typical flat face. See? One error triggers a whole cascade. Okay, so we've seen how things can go wrong with the plan itself. But what happens if the whole process is just cut short? This brings us to our second big topic, the challenge of prematurity. Any baby born before 37 weeks is considered premature. They are basically pushed into the outside world before their bodies are fully ready. And this is one of the single biggest causes of infant death around the world. And just to give you an idea of the scale of this problem, in a developed country like the US, it's over 10%. That means more than 1 in every 10 babies is born too soon. So you see, this is not some rare thing. It's a massive public health issue that affects so many families. So for a premature baby, what is the single biggest, most immediate danger? It's breathing. This leads to something called neonatal respiratory distress syndrome, or RDS. The main problem here is very simple. Their immature lungs don't have enough surfactant.
The best way to understand surfactant is to think of the soap in a soap bubble. It reduces surface tension and keeps the bubble from collapsing. In the lungs, surfactant keeps the tiny air sacs, the alveoli, open. Without it, the alveoli collapse every time the baby breathes out, and breathing becomes exhausting, almost impossible work.
And if we look at the lungs of a baby who has died from RDS under a microscope, we see something very characteristic. Look at this slide. See these thick, pink, glassy layers lining the air sacs? Those are called hyaline membranes. They are made of leaked proteins and dead cells, and they form a physical barrier that makes it impossible for oxygen to get into the blood. This feature is so important that RDS is also known as hyaline membrane disease. And this whole process creates a terrible, vicious cycle. It starts with low surfactant. This leads to the collapse of the lungs, which is called atelectasis. This collapse causes low oxygen, or hypoxia, which starts to damage the lung tissue itself. This damage then allows plasma to leak out into the air sacs, and that's what forms those hyaline membranes we just saw. And of course, those membranes make breathing even harder, which makes the hypoxia even worse, and the cycle just keeps spiraling downwards. But the lungs aren't the only danger zone for a preemie. Another major threat is in their gut. This disease is called necrotizing enterocolitis, or NEC. It is a very aggressive, very dangerous inflammatory disease where parts of the bowel wall literally start to die off. It can lead to a hole in the intestine, a massive infection, and it is a true life-or-death neonatal emergency. And these images show you just how devastating NEC is. On the left, you can see what the bowel looks like from the outside. It's stretched thin, discolored, and incredibly fragile. And on the right, when it's opened up, you can see it's dark, bloody, and dead, necrotic. This is an organ that is actively dying. A truly terrible sight. The extreme vulnerability of a premature baby's organs really highlights a bigger problem, the immaturity of the entire newborn immune system. And this makes them a perfect target for our third topic today, an invasion from outside. Perinatal infections are a huge threat to a system that just isn't ready to fight back yet. So how do these infections get to the fetus or the newborn? Well, there are two main highways. The first is called a transcervical or ascending infection. This is when microbes from the mother's birth canal travel upwards and infect the baby, usually during labor and delivery. This often leads to pneumonia or sepsis right after birth. The second highway is transplacental. This is when the infection is in the mother's blood and it crosses the placenta to infect the fetus directly. This can happen at any time during the pregnancy. Now, for those transplacental infections, there is an acronym that you absolutely positively must know for your exams. It is TORCH. Beta, this is incredibly high yield, rethamodulo. It stands for toxoplasmosis, other agents like syphilis and parvovirus, rubella, cytomegalovirus, and herpes. Every single one of these can cross the placenta and cause terrible damage to the developing fetus. Let's take just one example. This is from the O for other category, parvovirus B19. This virus is very specific. It loves to attack and infect erythroid precursors. These are the very young cells in the bone marrow that are supposed to grow up to become red blood cells. You can see here on the slide, the arrows are pointing to these huge glassy viral blobs inside the cell's nucleus. The virus basically hijacks the factory, shuts down red blood cell production, and causes a very severe fetal anemia. And that brings us perfectly to our final topic. What happens when a fetus has severe anemia? Well, one possible result is what we see here, a fetus full of fluid. This condition is called fetal hydrops. It's when the fetus develops massive, widespread swelling, or edema. It's important to know, hydrops isn't a disease itself. It's a sign, a very bad sign that something else is going terribly wrong. The classic cause, the one you must know, is immune hydrops, which is usually caused by Rh incompatibility between mother and baby. So let's follow the steps. An Rh-negative mother is carrying her first Rh-positive baby. During delivery, some of the baby's blood can mix with hers. This sensitizes her immune system, and she starts making anti-Rh antibodies. Now, in her next pregnancy, if that baby is also Rh positive, her antibodies, which are the IgG type, cross the placenta and launch an all-out war on the new fetus's red blood cells. This causes massive destruction of red cells, hemolysis, which leads to severe anemia, which leads to heart failure, which finally leads to the massive edema we call hydrops. So to quickly recap what we have learned today, we've seen that developmental problems can be intrinsic, like a bad blueprint in malformations, or extrinsic, like outside forces in disruptions. We've seen that being born too early, prematurity, leads to immature organs and life-threatening crises like RDS and NEC. We've learned that invaders can attack from the birth canal or directly across the placenta, remember TORCH. And finally, we saw how an internal war, like the immune attack in Rh disease, can lead to the devastating condition of fetal hydrops. So I want to leave you with one final thought. We've just gone through a whole list of potential disasters, right? Faulty blueprints, premature deadlines, foreign invaders, and internal battles. When you really stop and think about the billions of things that have to go perfectly right for a healthy baby to be born, doesn't it make you feel that every single healthy birth is, in its own way, a small miracle? Think about that. Thank you for your attention.
Chalo bacho, welcome back. Today we're going to tackle some very important topics from chapter 10. Now listen carefully. What we're discussing today, ये सिर्फ exam के लिए नहीं है. This is the real world stuff you're gonna see on your wards. So, let's begin. Okay, let's jump right in. Look at this. I know, it's a very difficult image to see, but we have to understand it. This, my friends, is hydrops fetalis. You can just see the severe generalized swelling, the edema, all that fluid that is built up all over the baby's body. This is the harsh reality of what happens when development goes terribly wrong. So the big question is, what is happening here? ऐसा क्यों हो रहा है? What is the underlying mechanism that leads to such a tragic situation? And it's not just this. What are the hidden genetic problems, these inborn errors of metabolism, can show up in a newborn baby? This is the mystery we're here to solve today. Okay, so here's the plan for today. We'll start with fetal hydrops, you know, the waterlogged baby. Then we'll get into some key metabolic problems like PKU. After that, a very important topic, cystic fibrosis. We'll look at the gene and then the clinical picture. And finally, we'll wrap it all up with the most important exam takeaways. Simple.
All right, so first up, fetal hydrops. The name itself gives you a clue, right? Hydro means water. So hydrops is basically a fancy word for too much fluid buildup. Let's dig into why this happens to a fetus.
Now, it's important to know that hydrops is a spectrum. It's not always as bad as that first picture we saw. Sometimes it can be localized, just a small collection of fluid like a cystic hygroma, often in the neck area, which, by the way, should make you think of Turner syndrome. Or it can be the full-blown generalized edema, what we call hydrops fetalis. So it's a range.
Okay, this is a 5-star must-know slide for your Viva. We can basically put the causes into 2 big buckets, immune and non-immune. Immune hydrops is the classic case you read about, the Rh incompatibility between an Rh negative mother and an Rh positive baby. This causes massive destruction of the baby's red blood cells. But, and this is the key point, today, because we have RhoGAM injections, this is much less common. So now, the more common causes are the non-immune ones. Think chromosomal problems like Turner's, heart defects, and other types of anemia.
Now look at this slide. This is a liver section. You see the normal pink liver cells, right? But look at all those little dark blue dots scattered everywhere. What are those? That, my friends, is extramedullary hematopoiesis. The body is so desperate for red blood cells that the liver and spleen are trying to make them outside of the bone marrow. It's the body's last-ditch effort.
So what's the biggest danger in all of this hemolysis? It's not just the anemia. It's this, kernicterus. When all those RBCs break down, what do you get? A flood of bilirubin. And this unconjugated bilirubin is poison for the brain. It crosses the baby's weak blood-brain barrier and stains the brain, especially the basal ganglia, this horrible yellow color. And that damage, it's permanent.
Okay, let's switch gears. We're moving on to inborn errors of metabolism. Think of it like this. The body is a huge, complex factory. And what happens if just one tiny, crucial machine, one single enzyme, breaks down? The whole assembly line can come to a halt, with disastrous results. That's what we're talking about here.
So let's start with a classic example, phenylketonuria, or PKU. The funda is very simple, really. There's an enzyme called phenylalanine hydroxylase, or PAH. Its only job is to change phenylalanine into tyrosine. Simple. But if this enzyme is missing, phenylalanine just builds up, and it becomes toxic, especially to the developing brain.
And if you don't catch this early, the results are devastating. Within 6 months, you see severe, irreversible brain damage, seizures. Another thing you'll notice is they have very light skin and hair. Why? Because tyrosine is needed to make melanin. And one more classic sign, a very peculiar musty or mousy smell in their urine and sweat. The real tragedy here is that all of this can be prevented. How? With newborn screening and a special diet.
Listen up. This is super important for when you're counseling patients. It's called maternal PKU. Imagine a woman with PKU who was treated as a child. She grows up, feels fine, and stops her special diet. Then she gets pregnant. What happens? Her own high phenylalanine levels cross the placenta and poison her baby's developing brain and heart, even if the baby is genetically normal or just a carrier. So, for these women, going back on the diet before and during pregnancy is absolutely critical.
Okay, now for a big one, a really important one, cystic fibrosis. If you can understand the basic problem with one single gene, the CFTR gene, then the whole disease will make perfect sense.
The definition really says it all. It's a problem with ion transport. The bad guy here is a gene called CFTR, cystic fibrosis transmembrane conductance regulator. Big name, I know. But what does a mutation here do? It makes all the secretions in the body, in the lungs, the pancreas, everywhere, incredibly thick and sticky. And that's where all the problems start.
Now don't get scared by this diagram. I know it looks complicated. There are over 2,000 mutations, but we group them into 6 classes. The main idea is simple. Look at classes 1, 2, and 3. These are the severe ones. Basically, you get no functional protein or very little of it. Now look at classes 4, 5, and 6. These are the milder ones. You still get some working protein. So the type of mutation tells you how sick the patient is going to be. Simple as that.
Okay, pay attention because this is a favorite exam question. It's a bit of a paradox. The CFTR channel does opposite things in different parts of the body. In the sweat ducts, its job is to pull chloride out of the sweat and back into the body. When it's broken, chloride is trapped in the sweat, making it super salty. Got it? Now, in the airways, its job is to push chloride out of the cell. When it's broken, it can't, so water gets sucked back in and the mucus becomes thick and dehydrated. 2 different places, 2 different problems, 1 faulty channel.
All right, so we've covered the genetics, the how. Now let's see what this actually does to a person, the clinical picture of cystic fibrosis. So, let me ask you a question. You've probably heard this classic story. A mother kisses her baby and says the baby tastes salty. Why? Think about what we just discussed. It's not just a story, it's pure pathophysiology. It's because that faulty CFTR channel in the sweat ducts can't reabsorb the chloride. That's why the sweat is so salty. And this is exactly why the sweat chloride test is the gold standard for diagnosis.
Just look at these 2 pictures. They show you better than any words what this one tiny gene defect can do. On the left, that's a pancreas, or what's left of it. It's completely replaced by fat and fibrous tissue because the ducts are all blocked up. On the right, that's a lung, totally destroyed by thick mucus plugs and nonstop infections, especially that nasty bug, Pseudomonas.
So let's just run through the major systems they get hit. The lungs obviously are the worst, chronic infections leading to bronchiectasis, the pancreas fails so you get malabsorption, the liver can get damaged leading to cirrhosis. In newborns, you can see meconium ileus, the first stool is too thick to pass. And another classic finding in males, almost all are infertile because the vas deferens is missing, all from one gene. Okay, Chalo, let's wrap this up. This is your final, high-yield summary. Everything you absolutely need to know for your exams. This table, take a photo of it, write it down, do whatever you need to do. It's pure gold. Fetal hydrops, think anemia, edema. PKU, pH enzyme, musty odor, diet. Cystic fibrosis, CFTR channel, salty sweat, lung infections. We've also added galactosemia here, which follows the same pattern. An enzyme problem, GALT, leads to jaundice and cataracts, and the solution is a galactose-free diet. See the pattern? This is how you should think.
And you know, I want to end with something hopeful. This isn't just a sad story. It's also a story of amazing medical progress. When I was a medical student like you, a diagnosis of CF meant the child would likely not live to be an adult. But now, with new treatments, new drugs that actually fix the faulty protein, the median life expectancy is almost 50 years. That's incredible. It's a huge victory for medicine.
So, I'll leave you with this question to think about. You guys are entering medicine in a revolutionary time. We've gone from just describing these diseases to understanding their exact genetic code, and now we're actually creating drugs to fix the broken parts. The next step? Well, that's up to you. How are you, the next generation of doctors, going to use this amazing technology to not just treat, but to actually cure diseases like these? Think about that. That's all for today. Thank you.
Good morning, everyone. Ciao bacio. Let's begin our discussion on some very, very important topics in pediatric pathology. Now pay close attention, okay? These are the concepts that are really going to stay with you throughout your entire careers.
So, here is our roadmap for today. We're going to start with a real medical mystery, and then we'll try to decode the diagnosis of SIDS. After that, we'll dive right into the world of pediatric tumors, looking at two big ones, neuroblastoma and Wilms tumor. And finally, we'll wrap it all up with the one key takeaway I want you to remember from all this.
Okay, let's dive into our first topic. We're beginning with one of the most heartbreaking situations you will ever encounter in medicine. A situation where the question why doesn't have an easy answer.
Now, this isn't just some hypothetical question from a textbook. No, this is a real, devastating event that parents and, yes, doctors have to face. The answer is, well, it's complex, and it leads us directly to our first major topic.
So, how do we even begin to approach a mystery like this one? Well, in medicine, we have a very systematic process. To understand what something is, we first have to be absolutely sure of what it is not. And this, my friends, is what we mean by a diagnosis of exclusion.
Right, so the crucial point to understand here is SIDS is not a specific disease that we can test for. It's not like an infection or a genetic disorder. It is the final diagnosis we arrive at only when we have ruled out everything else. Infections, congenital problems, abuse, absolutely everything. You could say it's an explanation for the unexplained.
So, what is the funda here? I mean, how can this happen? Well, the most accepted theory we have is this triple risk model. Think of it like a perfect storm. You've got a vulnerable boat, that's the infant, who might have a subtle issue, maybe with their brainstem's arousal control. Then you've got a tricky sea, that's the critical period of 2 to 4 months of age when reflexes are still developing. And finally, a sudden bad wave hits. That's an external stressor, like a minor infection or an unsafe sleeping position. When all three of those things happen together, that's when tragedy can strike.
Now, what's really important about this slide is it gives us clues for prevention. Just look at the environmental factors. That one, the prone sleeping position, sleeping on the stomach, that is probably the single most important modifiable risk factor. This is where you, as future doctors, can make a huge, life-saving difference with your advice to new parents.
And this slide right here, it brilliantly illustrates the power of that simple advice. This public health message, put your baby on their back to sleep, has saved countless lives. It's a perfect example of turning understanding into action. This is why your advice to new parents is so critical.
All right, let's switch gears a bit. While some of our challenges are about prevention, others are about fighting back when something has already gone wrong. And this brings us to the very complex world of tumors in children.
Okay, first things first, let's clear up two concepts that always seem to confuse students: heterotopia and hamartoma. A heterotopia is basically normal tissue that's just in the wrong place. Think of it as a geographical mistake the body made during development. A hamartoma, on the other hand, it has the right tissue in the right place, but it's all disorganized and overgrown. So one is an error of location, and the other is an error of architecture. It's a key distinction. Please remember it. And here we have a fantastic example of a hemangioma, a hemangioma. Look at that image on the left, at birth. Looks pretty scary, doesn't it? But now look at the image on the right. This is the same child just 2 years later. It's almost completely gone. It has spontaneously regressed. This is a very important point, Pacho. Not all growths in children are malignant. Some have this remarkable ability to just resolve on their own. Okay, on to our first big case file. Neuroblastoma. You must know this one. It's the most common extracranial solid tumor of childhood. These are the high-yield facts you absolutely have to know for your exams. The origin from neural crest cells explains why it so often appears in the adrenal medulla. That's a major hub for these cells. It's a tumor of the very young, median age of 18 months, which is why a large abdominal mass in a toddler should really set off alarm bells. And here's our clinical lifeline. These tumors often secrete catecholamines, so a simple urine test for their metabolites, VMA and HVA, can be a really powerful non-invasive clue that points us right to the diagnosis. Now, let's look through the microscope together, shall we?
What are we seeing here? Look closely. You can see these classic, small, round blue cells. They look very primitive, undifferentiated, and they're growing in these solid sheets. This is your typical small, round blue cell tumor of childhood.
And here is something truly fascinating that you'll see under high power. Look for this beautiful, almost flower-like structure, the Homer-Wright pseudorosette. You see how the tumor cells are arranging themselves in a neat little circle, and they're surrounding that central pinkish material, which we call neuropile? I'm telling you, when you see this in your practical exams, your brain should immediately scream neuroblastoma. It is a dead giveaway, an absolutely classic finding.
Now, this is crucial. A child's prognosis can change dramatically based on their genetics. Just look at this chart. For infants with metastatic disease, if the MYCN gene is not amplified, the survival is over 90%. But if it is amplified, my God, survival plummets to around 10%. A single genetic factor makes all the difference. This, Bacho, is why molecular pathology is the future. It dictates everything: prognosis, treatment, the works.
All right, let's move to our next big case file. Wilms tumor, also known as nephroblastoma. This is the most common primary kidney tumor in children. And you know what? Unlike our last case, this one is a major success story in pediatric oncology. So this is what it looks like grossly. A large, solitary, usually well-circumscribed mass that's often replacing a big part of the kidney. When you slice it open, it's typically soft, kind of tan gray, and looks pretty uniform. And microscopically, this is just a beautiful slide. It shows the classic triphasic pattern. Now, why triphasic? Because the tumor is trying to recapitulate or copy the development of a normal kidney. So you see three different components. You've got the primitive blastemal cells, those are the small blue ones. Then you've got epithelial cells trying to form little tubules. And finally, you have the stromal or mesenchymal cells in the background.
Now, this is extremely high yield for your exams. Wilms tumor can be a big clue that there's an underlying genetic syndrome. Wage and Denise Strash are both linked to problems with the WT1 tumor suppressor gene. Beckwith-Wiedemann is different. It's an overgrowth syndrome linked to the WT2 locus. So if you see a child with Wilms tumor, you have to think bigger. Could they have other anomalies? Knowing these syndromes is crucial for taking care of the whole patient, not just for passing your exam. And one more critical point. As a pathologist, if you find these nephrogenic rests in the kidney tissue around the tumor, you have to report it. Why? It's simple. Because they are the precursor lesions. Their presence means the child is at a much, much higher risk of developing another Wilms tumor in the other kidney. This finding completely changes how we follow up with the patient.
And we end this case on a very positive, very hopeful note. With modern combination therapy, surgery, chemotherapy, and sometimes radiation, the cure rate for Wilms tumor is now around 90%. This is one of the great triumphs of pediatric oncology, a true, genuine success story.
So, we have gone from an unexplained tragedy to tumors that we can understand, diagnose, and most importantly, treat successfully. So, what is the one single thing I want you to take away from all of this today? It is this. Whether it's a public health campaign for SIDS or molecular testing for neuroblastoma, the difference between a mystery that we cannot solve and a disease that we can master is knowledge. And your job as future doctors is to master that knowledge. Now go and study hard. Class dismissed.